I think the trade-off between performance and explainability is very, very fruitful for discussion around explainability in the field. So explainability, or the related term interpretability, I won't bother with the distinction, it doesn't matter very much, generally refer to the ability to understand and interpret outputs of the AI systems. And that ability is jeopardized by the complexity and abstraction of black box DNNs especially. So explainable AI, or XAI, is the effort to improve on that black box paradigm. And therefore, it is intimately related to AI ECG implementation science. And the implementation of AI ECG is the next frontier, is what matters. And therefore, it's arguably currently even more important than discussing about performance improvement. So explainability specifically matters because it empowers the clinician to make critical diagnostic and treatment decisions. And it is that transparency and understanding the reasons for an output that allows a clinician to validate an output against their own clinical judgment and expertise, and to integrate that output, that insight, with the clinical context and bedside assessment that cannot be mapped onto data. And that is what, this combination of factors is what ultimately matters for effective integration into the clinical decisions and workflow, which again is the limiting factor for AI ECG currently. And not only about explainability and reasoning, but the black box problem is also associated with bias, robustness, safety, liability, ethical use of AI, a lot of factors there, and these raise justified concerns that impede wide adoption of AI ECG. So how we are able to address these issues will determine how much clinical impact AI ECG can have. So it's critical to talk about these issues that will help build more trustworthy systems that can augment the clinical intelligence. It is also very important to emphasize that there are cases where explainability is unnecessary. There are many applications where great efficiencies can be achieved that are not critical, not diagnostic, not have to do with treatment decisions. So automation of non-diagnostic tasks, manual and administrative tasks, summarization of information, Copilot-like applications. So generally, large language models are great for that. So for all these kind of applications, explainability is not as necessary, not so critical applications, and we should not place unnecessary burden where it is not required. For diagnostic and treatment decisions, these are generally critical decisions, and the requirement for explainability is higher there. But there is this typical picture, and you saw that from Dr. Ang as well, that there is a trade-off around performance and explainability. I could give you a lot of citations where this doesn't apply, where structured, more explainable systems perform as good or better than deep neural networks. And often there is also a kind of treating these more structured models as black boxes. And if you do that, they will get worse performance, but there's a way to use them to structure information to a more higher level that can improve their performance while making them more robust and more meaningful at the same time. And I believe Dr. May will present some of that effort in his work. But let's put all that aside and let's accept that there is a trade-off, that performance and explainability, there's a trade-off there. And it's great because it captures that there are real trade-offs around implementation of AI ECG. So then we can ask, is explainability worth it if it comes with a trade-off in performance? And we can also reverse the question and ask, what are we giving up when we are improving performance with these systems? Explainability can stand in for a lot of things. It can stand in for empowering the clinician, making these AI ECG systems more robust and making them more effective for clinical integration, and therefore more likely to integrate into clinical practice successfully. So again, explainability can stand in for empowering the human clinician for critical diagnostic and treatment decisions, and in its absence, there is burden that is getting shifted to the clinician and the workflows. It means that it's harder to understand and trust the AI ECG inputs. The patient-physician relationship could be harmed, or require clinical education, or push the clinician out of these critical diagnostic and treatment decisions, more end-to-end, don't require human input. There's a lot of that vision that pushes the clinician out of the decision-making process. And if we think about the next step in the end-to-end axis are large language models. And no one today thinks that large language models are trustworthy enough for these critical decisions. And there is no bright red line between large language models and DNNs that make the DNNs more applicable for practice. It's just that DNNs are more constrained than large language models. And the same kind of constraint to the DNNs is what explainability is trying to do to make them more effective and have more success in being integrated into practice. So that is the importance of explainability. Again, help building trust and removing barriers to make these AI-HG models actually able to bring improvements in practice. So there are a lot of efforts, and the importance of that highlights why there are so many efforts into explainable AI. Dr. Ang presented a lot of fantastic work. There's a lot of value in this work. Just to point out, a common visualization output of all this work looks like saliency maps, like you saw before from Dr. Ang as well. These are a couple of the best groups in the world, amazing people in the authors lists, highlighting saliency maps to explain an output from a black box DNN on left Panderban's block on the left and on hypertrophic cardiomyopathy on the right. And because there is so much effort in the field, there have even been done clinical usability studies directly on the effectiveness of saliency maps. This usability study found that saliency maps are only slightly relevant and slightly helpful. And a common issue is discordance between regions that clinicians think are most important and what the DNN identifies. And you can see that even in these examples. Here you can ask, why are some QRS complexes identified and not others? Why is the QRST discordance not relevant for left Panderban's block? In the HCM example, there is an inverted T wave, but the deep and narrow Q wave should be a classical marker for HCM that every clinician should would look at to understand the context. And Dr. Ang pointed out very correctly that there is a distance between these tools being useful for clinicians, and there is huge value for the researchers to try to understand into these models more deeply. So these saliency maps allow probing into the model, and in that term, they are hugely successful in doing that. And the discordance with expectations, many clinicians, many authors would argue that it points to a limitation in the understanding of the clinicians rather than the AI-HG itself. And that is extremely fruitful. This is the dream of drawing more insight, especially for these deeper endpoints that we're hoping AI-HG can achieve. So there is very rich dialogue there. And for sure there are limitations in expert knowledge and in human reasoning that are getting in the way. So it's a very fruitful discussion. But when it comes to using this kind of explainability for helping clinicians in actual practice, there are inherent limitations for trying to interpret the black box. First of all, the internal representations are inherently abstract and inherently not interpretable by humans, almost by design. So there is also some ambiguity, oversimplification of how importance or saliency is defined. You can point to many things. But arguably, DNNs will always have an inherent disconnect from transparency and human reasoning. There is an extreme position here is that because of this, we should not consider using black box models altogether for these critical decisions. I think that's way too extreme. But it definitely highlights to a real limit in the accuracy and adequacy that these explainability techniques on DNNs can achieve. So this motivates methods that are inherently interpretable or explainable by design. And there's a lot of literature on that as well. This is a great paper by Professors Al-Zaiti and Bond that I recommend to everyone. Again, pointing to the motivation for this, the ability to justify and build trust to the systems, or even discover new patterns that weren't accessible before. So inherently interpretable or explainable by design systems have a lot of very attractive characteristics. They allow full transparency into the reasons for the output. They allow the clinician to assess and evaluate and make informed decision, and built-in domain expertise, guidelines, and structured reasoning. So overall, much more trustworthy vision. So it sounds like fantastic characteristics. The downside is that a great example of that is just expert rule-based systems. So this is arguably what's in practice today. So hopefully we can do better than just sliding down this trade-off scale and go back to where we started. But no one has used AI to improve these systems with a data-driven optimization before. And hopefully with AI, we can do that and improve these systems while maintaining full transparency. And this is, in fact, what we have achieved and what I will show for our work in the next session. But it doesn't have to be a vision that goes against DNNs. It can also be, a system like that could also be deployed in a hybrid or an ensemble configuration with the black box DNN in an effort that we get the best of both worlds. It could justify the black box nature of the DNNs to develop these models. So for all these weaknesses of black box models, there are incredible capabilities that are demonstrated. So the community is very eager to adapt them, even when configured as a black box. And a big part of the community is doing that today. A great rule of thumb in the literature is to accept the black box if the performance is much better than the alternative, and if the application is not too critical. It's a great rule of thumb because it highlights that there are real trade-offs along the lines of what we discussed today. So the fundamental question is, how do we want these AI systems to interact with clinicians and to integrate with the workflows? It's not about what a single patient or a single clinician would choose, but it's the entire workflow. Do we want the humans to be pushed completely outside these workflows and just blindly trust black box models? Explainability aims to improve and lessen the painful trade-offs that are required to bring these revolutionary capabilities to practice. Thank you.